Well, good afternoon and welcome everyone. I am Shelley Ellis. I am the director of the ICTR Dissemination and Implementation Launchpad and visiting professor in the Division of Hematology, Oncology, and Palliative Care here at UW. This is the Implementation Seminar, Science Seminar Series, and if you're new here, it's a monthly interactive seminar to learn about four pillars of the dissemination and implementation field. We talk about implementation theory, implementation methods, implementation strategies, and implementation laboratories, which is what we're going to talk about today. If you are new, please come back. We meet each second Friday of the month and at the same time during the academic year. And the seminar is open to all, not just at UW, but across the country. And we even have participants from Canada from time to time, and they're all welcome. So please come back. This is also, if you're interested, this seminar series is offered for credits in population health, and you can see me if you're interested in seeking credit. And we're proud to be part of the Implementation Science and Community Health Outcomes certificate program as well for graduate and professional and capstone students. So also another great program that folks should take advantage of, and we'd be happy to connect you with that. So today we're going to be talking about a learning health system collaborative platform, the LHS CP as it's known. And I'd like to introduce our speakers. I'm happy to introduce my colleague, Anne Gravel-Sullivan, who serves as the Associate Director of Research Translation and Implementation for ICTR's nationally recognized Dissemination and Implementation Launchpad, as well as its new Learning Health Systems program. With a passion for curriculum and systems design for impact, Dr. Gravel-Sullivan works to ensure these programs provide the next generation of biomedical and behavioral scientists with formal training and other services to advance their careers, to also accelerate their impact in translational research and improve health for all. Dr. Gravel-Sullivan's career spans 25 years of experience creating, managing, and teaching in professional development programs, including distance education. She has held leadership roles in several areas of medical education for at least 15 years. Most recently as the Executive Director of Distance Learning and of the Review Committee for the anesthesiology at the Accreditation Council for Graduate Medical Education. And prior to that, she served in several roles at UW, hospital and clinics, and the Department of Medicine related to continuing medical education. I also would love to introduce to you Dr. Sarah Westergaard, who is a faculty member in the Division of Hospital Medicine within the Department of Medicine. Her professional interests focus on oncology, enhancing team-based models of care to improve patient outcomes and promote workforce well-being and retention. She's a member of the Hospital Medicine Re-Engineering Network, cleverly with the acronym of Home Run, the Society of Hospital Medicine, and the Society for General Internal Medicine. Prior to joining UW, Dr. Westergaard practiced clinically in California and Maryland. She also volunteered with the Global Health Service Partnership, a collaborative effort between the U.S. Peace Corps and Seed Global Health, where she's taught medical students in Uganda and Tanzania for 2 years as part of a workforce capacity building program. Welcome to our seminar series. And with that, I'd like to turn it over to Dr. Gravel-Sullivan. Thank you.
Thank you so much, Shelley, and welcome everybody. We're really appreciative that you're willing to spend your noon hour with us. So what I'd like to do is provide a brief introduction to the Learning Health System program at ICTR and what it means to bring a learning health system approach to your work as a clinician and researcher. I'm going to walk through some of the characteristics that distinguish it from other approaches, particularly QI, quality improvement, and then share briefly an example of a project that we've done so you can see how those elements, those characteristics stand out before Dr. Westergaard presents on her LHS demonstration project. A learning health system is essentially a data-driven, multidisciplinary, implementation-focused approach, that's a mouthful, to improve healthcare delivery by measuring one or more of the quintuple aims. Um, it brings expertise from many fields, clinical informatics and biostatistics, to implementation and team science, and brings that expertise to bear on goals that are closely aligned with the strategic priorities of the local health system, in our case, the UW Health. And it uses aligned metrics as well to evaluate effectiveness. Now, part of the point of an LHS approach is to implement evidence-based interventions that have the potential to improve the healthcare system quickly and viably so that its impacts are evident and they can be sustained. This means that elements of implementation science, project management, data monitoring, and outcome evaluation tools are put in place to help measure the value that it brings to the health system. These processes contribute to the ability of system leaders to make decisions about what pieces of infrastructure to adopt or build based on the return on investment that they see coming from the project, and then to ensure that any new standard of practice is going to be sustainable. To this end, LHS projects are designed to be reproducible into other healthcare contexts and therefore to create products of different kinds, like it could be software code, it could be digital tools or training guides that permits others to go and use to implement, replicate the intervention at their local institution. While people often assume that an LHS approach is very similar or the same as quality improvement, and they do have a lot in common, there are some key differences. For example, while quality improvement can be practiced at the micro as well as macro level, say in a single clinic or lab, part of the value of an LHS approach is that it identifies interventions that are mature enough to be adaptable to new settings, but then that they're also scalable. We've adopted the adage that we learn from what we do and we do what we learn as a kind of a banner for learning health systems because it reflects the pragmatic nature of the design of the approach and it incorporates continuous improvement processes into its implementation design. One of the challenges of an LHS approach is that researchers must design their intervention in alignment with the local health system's operational timelines, which, as you know, move very swiftly in clinical settings. Because LHS interventions are evidence-based approaches, they use evidence-based approaches in implementation, they have to grapple with the challenges of maintaining scientific rigor at the same time that they are rolling this out in a clinical setting, which is not easy to do, particularly when a rapid scale-up is involved. By contrast, not all QI efforts are grounded in evidence-based interventions. You hope they are, but they aren't always. Nor do they bring a scientific research design to improving healthcare. Now, this tension tends to follow LHS proposals into the development of their protocols and submission to the IRB, which reviews them not as quality improvement, but as minimal risk research projects usually. Sometimes it'll be a little bit, if it involves human subjects, it's a little different. But that category tends to walk the line between quality improvement and full-blown research and brings some unique challenges along with it. I think Sarah will probably talk a little bit about some of those. There are two kinds of LHS projects at UW Health. One is an executive level project, and the other is a demonstration project. The executive level projects are identified by UW Health leadership, and the Institute's LHS program collaborates with UW Health leadership, project managers, to integrate our research implementation efforts with their their operations team. We have adopted a bidirectional governance structures between the two entities that has been very successful at being effective, we found. And thus far, we have used this particular type of project to primarily assess interventions that integrate new technology, particularly AI, into workflows. This is in contrast to the demonstration projects, which are investigator-driven. We offer a funding opportunity annually, have awarded now 3 different awards to people, and Dr. Westergaard was our inaugural awardee, I'm happy to say, of this competitive uh, project. It's co-funded by the Institute and UW Health, and we've got two more that we're offering next year. So I encourage you, if you're interested, to check out our demonstration project webpage to find out more about the RFA and that funding opportunity. I'd like to briefly describe one of the more visible executive projects that we've taken on in the last year. You may have heard about the Ambient Listening AI project. This was a partnership between the Institute and UW Health, and it's received some nice attention from the media. And the results of the two phases of this project have been published in the New England Journal of Medicine AI. Um, Essentially, the project goal, which was brought to us by Joel Gordon, the Chief Medical Information Officer at UW Health, it was to see if there was a way that really assess whether or not the ambient listening tool, which could be used on one's iPhone and in the context of an outpatient encounter, and essentially record the conversation and pre-populate the electronic healthcare record, saving potentially a lot of work on the behalf of the provider. So, formally, out of that desire to see if that documentation burden could be reduced and more face-to-face time could be attained with the patient, came two goals. One was for our implementation phase, which was to see if we could build a PTOps playbook that could integrate effectively research analytics into an operational workflow and timeline. The second was to measure the efficacy of the tool, the scribe, and we partnered with a bridge, the company on that, to improve healthcare practitioner well-being. We used as measures elements of the professional practitioner well-being index that the hospital already had in place, and a tool utilization set of metrics as well that included time spent on notes and work outside of work. We used what is largely considered the gold standard of LHS projects, and that is a pragmatic clinical trial design for this project as well. The governance structure, as I mentioned, was run both by project managers and leadership on the UW and the Institute side. We collaborated with Jason Dambach, our clinician lead, to design an effective workflow that would not be disruptive for the practitioners desiring to use this application. Tested and trained people on how to use it. The clinical documentation team worked very closely with us to ensure that coding was accurate and had high reliability. And the other regulatory leads also made sure that, once again, we integrated into the existing infrastructure, contributed to it without disrupting it. The analytics team worked with UW Health Enterprise Analytics to build a real-time data dashboard to monitor the flux of its usage and make sure that it was being used safely and appropriately. And we developed a provider scorecard as well, that once a provider's use of the tool fell below a certain threshold, they would receive a letter, their department chair would receive a letter notifying them that if they did not step up their use, that this had the potential to be reallocated to somebody else, thus making sure that we were spending wisely. Our evaluation showed that there was, in fact, a meaningful reduction in burnout, and I encourage you to both look at our New England Journal article on the trial, as well as check out our public GitLab website. As I mentioned, reproducibility and leaving people with something that they can implement is a super important part of the LHS approach. Finally, we do have some educational resources that are available on our YouTube platform in Learning Health Systems. We have a podcast, The Learning Loop, that I urge you to check out. You can sign up for our newsletter, and I know we haven't had a lot of time today, and we're going to defer questions to the end of Dr. Westergaard's presentation, but please reach out at any time with any questions about Learning Health Systems. With that, I'm going to thank everybody and turn it over to Sarah.
Okay, so Thank you for that introduction to the LHS, Anne. So I'm Sarah Westergaard. I'm a hospitalist here at UW. Um, just real quickly, I don't have any disclosures, but the project I'm going to talk about was funded through the ICTR CTSA. And also, just as a disclosure, I am not an implementation expert, but I am quite enthusiastic and excited to talk to you about our PHP team here at UW. So just kind of an overview of what I'm going to talk about. So I'm going to give just a little bit of background on hospital medicine for those of you who are not clinicians. Um, and then I'll start talking about our team preparing for change and our approach. I'll talk about our team's implementation and how that relates to the LHS, and then I'll get into some of our early outcomes and lessons learned with the project as well. So for some background on hospital medicine, hospital medicine at UW Health is quite large. We're one of the largest divisions. We currently consist of about, I think, over 80 physicians and around 20 or so APPs. We divide our time between two hospitals here on campus. So University Hospital is the main campus. It's a 505-bed hospital. Multiple specialty services are available here. And we have about seven direct care teams at University Hospital, and then like four or so teaching teams here as well. Um, at East Madison Hospital, smaller hospital on the east side of town, 83 beds. Generally, lower acuity patients are seen there. We have fewer subspecialty services available, and we have four hospital medicine teams there. And so just as a little bit more background on kind of hospital medicine staffing models. So as hospitalists, we are only taking care of patients when they are admitted to the hospital. And so historically, the scheduling structure for hospitalists has been that you work 7 days in a row and then you get 7 days off. That model has evolved over time, but it largely still follows that. And so for our hospitalists who, there are 11 direct care services between University Hospital and East Madison Hospital. When you're doing that week on, week off, when you come back onto the team, you may not be coming back onto the same team that you had just rotated on. So, for example, our hospital medicine services at University Hospital are numerically labeled. So, HOS 1, HOS 2, HOS 3, et cetera. East Madison is ABCD. So 1 week you could be on hospital medicine 2, you're off for a week, you come back, you're over on EMHD. So there's not a lot of continuity from week to week. And so what happens with these models is that it's created a lot of fragmentation with the care that's being delivered. And so I'll walk you through how this impacts a patient. So a patient gets hospitalized and they are assigned to a hospital medicine team. Now, depending on when that patient is admitted during the week, because we come on service on a Tuesday through a Monday. So if that patient is admitted on a Tuesday, they're likely going to have continuity with the same hospitalist throughout the week. But if they're admitted on a Sunday or Monday, there's going to be increased fragmentation as well. And this obviously also depends on how long a patient is admitted as well. When they're discharged, they're going to be sent back to the care of their primary care team. For the vast majority of patients who only have this one isolated inpatient stay, this model works perfectly fine. The problem happens when patients have recurrent hospitalizations. So the next time they come in, they may get assigned to a totally different team, totally different set of clinicians taking care of them. And those clinicians have to relearn what has happened on prior stays, and this can become very dissatisfying for patients as well as providers. Patients get discharged back to the primary care team, although sometimes we often have patients getting readmitted before they're even able to establish or follow up with outpatient providers, and then they get readmitted again. So you can just see how problematic this cycle can become. So just for kind of put this into numbers. So for someone who has 3 hospitalizations with our model where we have 11 different teams, there's a 1 in 11 chance that they're going to get readmitted to that same team. And so if we multiply that over the 3 hospitalizations, the chance of them getting readmitted to the same team is less than 1%. When we take into consideration all of the different providers that a patient could see, it's a very minimal chance that they're going to see the same person on a subsequent hospitalization. And so our innovation that we proposed was our primary hospital provider model. So the idea being that when a patient is hospitalized, they get assigned to the primary hospital provider team. And this is our innovation is that we were trying to cohort a smaller group of hospitalists. We settled on 7 physicians and 2 APPs who would exclusively rotate on this one team, and they would set up meetings during the week to talk about patients who had been assigned to this team, who were being seen more frequently, so that when they come back in, they would get reassigned to that team, and we would have some continuity with them through subsequent hospitalizations. Our thought was that this type of model was most likely to impact patients who we define as high need, high complexity, who are having frequent hospitalizations and frequent encounters with the healthcare system. That the current model, in combination with those types of patients, was leading to poorer patient outcomes in the sense that they're getting multiple tests, using additional resources, can also lead to patient dissatisfaction and mistrust. And then on the provider side, leading to cognitive overload and burnout. We recognized that there was an opportunity within our health system to address this. Readmissions has been an ongoing area of a priority area for the health system. And we identified through some preliminary data that there was a large population of patients who were being hospitalized multiple times throughout the year. So in fiscal year 2023, there were nearly 1,500 patients who had 2 or more hospitalizations to a hospital medicine team at either University Hospital or EMH. 510 had 3 or more. And then compared to other peer institutions, UW Health ranks relatively poorly in terms of their readmission rates. Additionally, just thinking about the cost, so it's been well documented that 5% of patients account for about 50% of health expenditures. So if there are ways that we can try to target care specifically for this patient population, we may be able to reduce cost. So as all of these ideas for this innovation and this team were brewing, the other opportunity was that ICTR had announced the inaugural LHS Demonstration Award. And so as Anne has kind of touched on, thinking about how we could implement this innovation, but doing it a little bit more rigorously with these PDCA cycles, and knowing that the proposal the team that we had structured really met a lot of the quintuple aims. So talking about patient experience and provider well-being, I talked about cost reduction, and then certainly thinking about health equity as well, and how providing care for patients, providing kind of tailored care for patients who need it the most. And so our approach to the team, the first step was to redesign one of our clinical teams and recruit clinicians to be on the team. And so we were very intentional about how we wanted to create this team. We wanted it to be small enough that we had a cohesive group of people, but not so small that if someone left, it would be hard to replace them over time. But also, we recognize that these patients, because of their complexity, required increased attention, and that this wasn't, what every hospitalist wanted to do. This wasn't a service that we were forcing anyone to rotate on. These were people who were interested in delivering this type of care. So I reached out to some of our current hospitalists, and then as we were recruiting new hires throughout the kind of normal recruitment process, also discussed the team. And so, like I said, we had 7 physicians, 2 APPs, and I'd say about it was 50-50 of you know, clinicians who are already part of the team versus some new hires. So that was the first step. So we were just redesigning one of our already existing clinical teams. We were not asking for new FTE for physicians or clinicians. This was all just kind of restructuring how we were using one of our clinical teams. At the same time, we were working to build relationships that were aligned with the health system goals. And so meeting with various health system leaders. Um, I'll also mention that there was really, we talk about the opportunities kind of earlier on, but there was also this window of opportunity with uh, when this idea was coming up, we had a new division head, Ed Vasilevskis, who was joining us from Vanderbilt, who also happens to be a research mentor of mine. But as he was kind of making his introductory tour around the health system, he was kind of planting the seed about the team. And so it made it very easy for me to then follow up with these various health system leaders about our idea and get buy-in from them. I already kind of talked about some of the pain points and opportunities. One of the other things that has come up is that pediatric complex care patients who are making the transition to adult medicine, that's has been a challenging time, and that perhaps this team would be something that could target that. I talked about the readmission ranking and some of the health equity goals, and then also just thinking about some of UW Health strategic priorities as well. So I had previously mentioned how we were trying to target this team for the patients who we thought would benefit most from this type of care. Also recognizing that we wouldn't be able to take care of all 1,500 of those patients who had had 2 or more hospitalizations. So how could we try to titrate that to optimize the potential impact, some of the operational realities, but also make this rigorous? And so our thought was to take patients who had had 2 or more hospitalizations to a hospital medicine team within the last 12 months, and then also layering on some of the technology that had been introduced through the EPIC readmission risk score, which takes into consideration various social determinants of health, other medical conditions, and kind of populates this risk score into the electronic health record. And so using that to help us titrate the patients that we would include on this team. I've listed some of the exclusion criteria below. The 2 that I want to touch on are that we opted to exclude patients who had a UW family medicine provider as their PCP, our reason being that family medicine has their own inpatient service at UW, and so they are preferentially admitting their outpatients to that team. On hospital medicine, we would see them as overflow, but there's not always consistency or continuity with that. And so we didn't want to kind of muddy the waters there. And then we also elected to exclude patients who had a primary cancer diagnosis that was actively being treated for the reasons, a couple different reasons. One, we have a hospitalist oncology service for those patients, but also through some preliminary work that Ed had done at Vanderbilt previously. These patients are hospitalized for kind of a short period of time where their cancer is active, but then they're either going to get better or they're not. And so the likelihood of them benefiting from this continuity model was probably less. And then lastly, with the learning health system model, we wanted to design our study as a pragmatic clinical trial. So studying an innovation in a real world setting rather than in a kind of as a controlled clinical trial. And based on the kind of short time period of the LHS, it's a 12-month grant period, we elected to focus on feasibility as our primary outcome measure. So patients who were assigned to our PHP team who were were we able to get patients who were initially assigned to the PHP team readmitted to the PHP team on a subsequent hospitalization? That's all we really thought that in a 12-month period that we would be able to determine. But we did want to look at some exploratory outcomes in terms of patient and provider experience. So I'll jump into implementation and how we have been working with the LHS over the last year. So our proposed timeline, so I was notified of the grant, I think in about August of 2024, and I was pretty quickly able to get things through develop my protocol and get things through the IRB so that we could start the grant October 1. We already had our clinical team in place. I'd worked with our clinical leads to have our schedule so that all the hospitalists rotating on the PHP team were already in place. And I'd already started to meet with the HealthLink research team to create a BPA, which I will talk about in some subsequent slides. And this was the technology that we were using to be able to randomize patients. And so we had proposed starting to enroll patients in mid-October, enroll them for 9 months through mid-July, and then we would continue to follow patients for readmissions over the next couple of months with the goal of completing our data collection in September and doing our analysis and final report for the end of the grant period. While we were enrolling patients, we had planned to do a couple rounds of patient and provider interviews in February and June to explore some of those perceptions. So again, this was the proposed standard or the proposed timeline, and this is how things actually have gone for the last year. And this slide is intentionally messy because this is just to demonstrate how nonlinear this process has been over the last year. And so I'll break this down a little bit because this is quite messy. But I think the first thing to talk about is just how we use the technology to enroll patients. And so this was through the development of a best practice alert, which is a tool within the electronic health record. So when you open up a patient's chart, there are these best practice alerts that will fire for any number of different reasons to kind of help with practice management. One that commonly fires for us is that if a patient has sepsis or meets sepsis criteria, it takes us through a different order set that would be kind of helpful in terms of clinical management. Our thought was that we could use a best practice alert to identify patients who met the eligibility criteria to enroll in the team, and that our hospitalist who is working in a triage capacity, so 7 days a week, 24 hours a day, we have a hospitalist who is taking calls from the ER, from the access center to admit patients and kind of direct traffic to which service they get admitted to. And so our thought was that we could use this BPA, use the technology within the electronic health record to identify those patients so that triage would be able to enroll and then randomize those patients to either our PHP team or to usual care. This was a new build for the HealthLink research team. This is something that it's not a new build entirely, but for the research team that is here at UW, this was a kind of a new workflow for them. And there were multiple, because it's something that's, patient or not patient facing, but user facing, there were multiple layers of approvals that this needed to go through in terms of clinical decision support. And so that ended up taking longer than anticipated. At the same time, we talked about this being a pragmatic clinical trial and that we were trying to implement an innovation kind of in a real world setting. And I think there are still a bit of a mismatch within some of the regulations in our kind of system in terms of what approvals does a pragmatic clinical trial need? And this is something that I worked really closely with Anne and Majid and the Learning Health System. And I know they're aware of some of these challenges as well and have been working to address that. But how can we kind of more seamlessly get a pragmatic clinical trial through some of those approval channels? So as I was developing this BPA, this was going to be a new workflow for our team as well. And so I was also providing a lot of education through division meetings. We have a weekly email announcement, and then I was developing some education documents. So the BPA creation was ongoing through October and November. We finally thought we got to a point shortly or in December. It was right before the holidays to go live with the BPA. And then pretty quickly, I think within 24 hours, recognized there was a significant glitch with that and we needed to pause the BPA over the holidays. We were finally able to formally launch the BPA in January and begin enrollment. We also were able, through some of the funds from the LHS, able to hire some FTE for a case manager who was focused on transitional care follow-up. And so he became part of our kind of weekly clinical meetings as well. I also will note that because of some of the delays with getting the BPA up and running, I had to put some of the qualitative work on the back burner, and so didn't really get a start on that until January of this year. Sorry. So once the BPA was launched, we really wanted to start those PDCA cycles to see, were we actually getting patients enrolled that we wanted to? And so our plan was to, make sure we had appropriate enrollment by implementing the BPA. And so the plan was to do these weekly reviews of enrollments. And so I had reports, or I had planned to have reports to see who was, eligible, who was getting enrolled, et cetera. And unfortunately, some of my ability to access those reports were delayed again by some approval channels with HealthLink on the health system side, and then CURDS through some of the data that my data analyst was getting for me. Eventually, I was able to review the enrollment data, and by doing so, made some adjustments to the readmission risk score to make sure we were meeting our target enrollments. And then we also, because this is there's always human error in design. And so there were some patients who were inappropriately enrolled. And the HealthLink research team helped me create a correction BPA to be able to reassign some of those inappropriate enrollments. So I'll kind of hopefully speed through some of this. We were eventually able to, there's a lot of back and forth in the development of our IRB. So the IRB that I initially had approved was for patient enrollment. We were delaying the qualitative IRB until we could, kind of develop our research questions and interview guides for that. That happened in the spring of this year, and we ended up being able to recruit and complete interviews with the hospitalists in June and July of this year. In doing so, we wanted to look at the acceptability of the BPA from the triage hospitalist aspect or perspective. And so the planned check had been to do interviews with triage hospitalists. However, with our timeline, this was, 6 months past the initial implementation of the BPA, which, and thinking about the feedback, that's quite delayed. And what ended up happening was that I got a lot of informal feedback from the triage hospitalists just about their experience working with the BPA, noting that it was firing inappropriately, that there was some extra noise, which was very helpful. And I tried to make myself available to different members of our team just to let them know to let me know if they were having any issues with the BPA so that we could work with the research team to correct that. And so over the course of several months, I would say that the research team worked very hard to kind of smooth and reduce the extra noise in the BPA so that it wasn't firing as inappropriately as it was initially. We interviewed the hospitalists on the PHP team as well to understand, was this redesign of the scheduling structure acceptable to them? And this came through the weekly PHP team meetings and the interviews with the PHP hospitalists then over the summer. And through some of the feedback through the weekly team meetings, we were able to better optimize the team's functionality. We met with various specialists whose patients we may have been we were seeing more frequently. So, for example, there are some patients with sickle cell disease, so met with the sickle cell experts. We had some meetings with the ER team about how they address patients who are more frequently hospitalized and dealing with care plan development. So I'll just kind of wrap up here to show you that you'll notice that there's a lack of interviews with patients and caregivers on this timeline, and I'll get into that a little bit more with our lessons learned. The patient population that we are dealing with, the high need, high complexity patients, are very sick. And I don't know that I fully appreciated just how sick this patient population was going to be, and that their ability to participate in a 45-minute to an hour-long interview during a hospitalization is probably not where they wanted to be spending their time. And that's even for the patients who didn't have some cognitive dysfunction or weren't or were able to participate. A lot of our patients, unfortunately, were altered or were unable to participate or unable to give consent. And so what we ended up doing was expanding our IRB to be able to include caregivers to understand to try to understand what their perspective on having a loved one who was frequently hospitalized and their interactions with the healthcare team. There's a little bit of back and forth with the IRB on that in terms of getting consent and assent from patients. So that ultimately didn't happen until October. So anyway, and that has not happened to the extent that I think I had initially planned. You can see in September, we were able to get through or complete the period of enrollment, and then we continued to do data collection through November, and we're in the midst of our final data pull right now. So I don't have a ton of outcomes to share with you, but I can share just some kind of initial early outcomes. So over the 9-month period, we enrolled 144 patients, and this is to both the PHP team and to the usual care team, so the two arms of our study. 55% were female, 45% male. The mean age at enrollment was 58.5 years. We've just reached the 11.5-month kind of follow-up period, and so we're currently doing our kind of final data pull. I actually have a meeting this afternoon to meet with our data analyst and biostatistician about that. So hopefully there'll be more data to share soon. Some early outcomes from the interviews with the PHP hospitalists. We conducted 7 semi-structured interviews with our PHP team members. We were using the CFR, Consolidated Framework for Implementation Research model for our analytic framework. Some of the early themes that have come through is that the changes to the hospitalist workflow were appreciated and deemed to be sustainable. The weekly team meetings were felt to improve quality with minimal added burden, which was something I was pleasantly surprised by. I thought Here we're asking clinicians to take an extra half hour out of their week to talk about patients that when they may not even be on service. And yet our team has consistently been engaged and did not feel that that was adding extra burden. And that the reorganized workflow helped clinicians feel better equipped to understand the backstory of each complex case and the care that had previously been provided. So I just pulled a couple of quotes that I think are uh, helpful. So one team member said, I do look forward to Wednesday meetings when I'm not on service because it's always a break and a good break to like just tune in, learn about our patients, see if any updates and how we can be helpful. And another team member said, I feel like actually it increases the physician's or provider satisfaction too, because when you already know your patients, when you're interviewing them, you already know the social aspects of their health. We also interviewed the triage hospitalists, like I mentioned, so another 7 semi-structured interviews. We're using the CEIPS model as our analytic framework. And again, just some early outcomes that are, or early themes that are coming through here. And we recognize that the BPA is clunky, and so it's created an additional kind of workflow for the triage hospitalists, and they described this kind of misalignment of their workflow and felt that it could be better designed. What's interesting, though, and I don't know if this is just I think this is a broader theme amongst clinicians, is that yes, it could be better, but hospitalists also just commented that whatever, it's what we do. And so they described the process as acceptable, even though they were relying on workarounds to get through it. And so I think that's just something to take into consideration when we're developing new technologies and how to get the most from that. So I'll just kind of quickly end with some lessons learned here, because I know we're running short on time. So our study, where we were trying to get a primary outcome that was studying feasibility, in general, our study over a 12-month period didn't feel very feasible. And I think I spent a lot of the last 12 months in this space of I don't know what I don't know, which is a very uncomfortable place for me to spend my time. And that's been a bit of a challenge as well. So I think there's a lot of things that I just didn't know going into this. This was my first study that I led as a PI. And so it's also just been kind of figuring out different approval channels and who do I talk to about this, and yeah, just trying to get things done was a challenge. Another lesson learned. So PDCA cycles in an LHS should be rapid. Qualitative interviews are not. I think there are better ways that I could have gotten some of the acceptability information more quickly, particularly with a 12-month grant. That being said, we've gotten some really rich data from our qualitative interviews, and I certainly think that there's a role for them in implementation research. I think there's just a bit of a mismatch, though, with the pace that an LHS is run in. Another mismatch is between the need for the rapid data collection and a lot of the various approval systems that I encountered. And so I don't think this is unique to UW Health or the health system that we work in, where there's the health system and there's the university, and kind of getting everyone to talk when you're trying to do research can also be challenging. And then lastly, recruiting patients for interviews, especially those with complex medical conditions, has proven challenging and required additional time and planning. I already talked about, this chronically ill patient population, highly morbid, high mortality rate also amongst our patients. And so that, I think, has really, really impeded our ability to get the patient's perspectives on this innovation. But I do want to end on some of the successes of the team, and I just really want to highlight the hospitalists that we have on the team. So these are the 9 currently. We had one physician who moved out of state for other reasons, but not because of the PHP team, but was replaced very seamlessly by one of our new hires. We've had a couple of gatherings outside of the hospital. These are just a highly engaged, compassionate group of clinicians that has just been a delight to work with over the last year. And then I have a picture on the right of our nurse case manager, Matt Lakoski, who's been amazing as well, has a wealth of experience with transitional care, and has attended every weekly meeting with us as well. And just I'll mention, so we're continuing to meet every Wednesday at 2 p.m. We met 2 days ago. We have one patient currently hospitalized who's a PHP patient. Just because as the BPA was paused, our enrollment numbers have, kind of dwindled. All but one person on the screen was on that meeting. So we had 9 people present, who, only 2 of them are actively on service right now, and yet everyone was engaged and wanted to be able to help out and provide input. And so I just can't say enough about the team of people I have working with me. And then lastly, this kind of touches on some other facilitators. The work we're doing is mission driven, and I think people want to feel like the work that they're doing is meaningful. I think as clinicians, there's a lot of moral injury and feeling like the system isn't working for you. And so if you're able to participate in some type of work that feels like you're doing some good in the world, I think there's a lot of satisfaction and retention that can be uh, provided from that. Some of the other facilitators, again, just the alignment with the health system priorities, had stakeholder buy-in. I didn't even talk about how we had convened a interdisciplinary stakeholder group that's been meeting quarterly to kind of talk about the team. I've had really strong partnership with Andrea Whipperfirth, who's the director of the Care Continuum at UW Health. She has been a really great asset. The supports I've gotten through ICTR, I mean, I mentioned that it's has been challenging to kind of figure out who to talk to for different things, but the ICTR folks have been really helpful. And then the informatics team through the Health Link research team in developing the BPA has been really helpful. So just wanted to list all of the people who have been instrumental in getting this team up and running over the last year. Yeah, it's been great. So sorry, I went over my time. I hope that I left a little bit for Q&A, but I'll stop sharing now.
Thank you so much, Sarah, and to Anne as well. And this is fantastic to hear about, really what's a pioneering effort in UW to create this learning health system and to figure out how to make it work. I think we're all committed to the idea that, this is the way to improve care, and it would be great to hear some questions that you have about the work that Sarah and her team have done and about learning health systems in general. And just to get things kicked off, I wanted to follow up on Sarah's question and maybe bring Anne and others in to think about what kind of campus resources, study teams, or services have proved helpful in getting the LHS established and demo projects implemented. Are there particular things, if others are thinking about doing applying for this grant or doing a demonstration project, that they would maybe turn to help potentially shortcut? Implementation science is never a linear process, but shortcut some of the challenges that you all faced.
Yeah, I would say, so as part of the LHS, we had an early meeting with the team science folks to get everyone on board. So my research team that I had constructed, and I think it was a really helpful framework to just think about. Again, this was my first experience leading a team, and so I didn't know a lot of the questions to ask, and I think that kind of helped frame things through the course of the year. I think one of the things that came up that I think would have been helpful to have thought about earlier on was there was a question about like who was the project manager for this team. And so that wasn't something that I had even built into the grant or to the budget. That didn't even cross my mind. And so I think I ended up being the project manager, which it requires a tremendous amount of work that I think could have been helpful to think about that earlier on. Um, I don't know, Anne, if you have thoughts on like if there's like a central resource in terms of some of those questions or how you guys are trying to streamline like the clinical trial. I mean, there's just a lot of approval channels that need to occur and who you guys are using as a contact for that.
Yeah, that is a challenge. And it's varied depending on the specific nature of the challenge. We tried to do some upfront work, and I give Majid a lot of credit for really doing legwork at the beginning and meeting with legal, the folks on the legal team that are a little higher up. So and we do have representation on the steering committee from the legal team, so that helped initially. But as you get a little bit more granular on some of these issues, we've had to kind of engage different levels of stakeholders. There have been some that have been super helpful. Monica Esquibel comes to mind. She has really kind of immersed herself in trying to understand this approach better and help us figure out how to streamline things in the review process. But that's it's clear that there's still a lot of work to be done too. But this is something I think is actually super worthy of closer exploration and brainstorming. There are some institutions, and maybe Ed can speak to this a little bit, like Vanderbilt, that actually have streamlined this process to a degree that is really admirable. And we have something to learn from them too. So, I don't know, Majid, I think is here. I don't know if you want to say something in addition to that. Might have dropped off. Yeah. So yeah, he dropped off. No, he's there. Ed, I see you've come off camera if you
Yeah,
want
I
to
was
say
just going to
something.
say just a couple things. Sarah mentioned about the project management. I can speak from the Vanderbilt. Like they have a learning health system, kind of like it's plug and play, essentially, where there's a built-in project manager who knows how to do pragmatic, who knows those connections. So probably I think a goal for ICTR would be to have that type of person who would be able to be a resource to multiple projects, who has those legal connections, Kurt's connections, informatics connections, because there's stuff that just built over time, and and with various projects, people are going to have to recreate the wheel. Another, I think, huge advantage that Vanderbilt has is when patients get kind of brought into the system, it's essentially it's an opt-out philosophy. So when you sign in to be cared for Vanderbilt, you're automatically signing in to have pragmatic research done. There isn't an additional kind of layer of approvals that has to be done. So to do pragmatic research, there's just that opt-out versus opt-in makes a tremendous difference.
Great. One question in the chat is like, what are the alternatives to doing like testing this model of care you might have might be a quality improvement collaborative? And just curious if, given your experience, would you consider maybe your R01 that follows this study maybe in a different setting, or would you try to follow on in an LHS?
Um, I don't know. That's an excellent thought and question. One thing, that we've talked about is, um, these types of teams exist in other institutions in some type of capacity. But we don't really know like what is the best model. Is it having a smaller cohort? So Vanderbilt has a team like this. University of Chicago has a team. Rush is developing something as well. And so, like, what are uh, who are the people that need to be involved in this? What does the actual system and kind of structure of the team look like? And so thinking about kind of uh, doing a deeper dive into what the teams themselves look like, I think has been kind of the next step that I've been thinking about.
Great. Well, thank you, Sarah, and thank you, Anne, for bringing this to us. I'm sure a lot of folks have additional questions, and I'm sure that Anne would be happy to uh, provide additional context as well as Sarah. And just to put it in plug for the work that Anne does nationally with the translational science centers, the CTSAs, in terms of a working group, and there are podcasts and other resources that are available if folks wanted to follow up and get more information. Uh, Please fill out the survey to tell us what you thought about today's activities and what kinds of programs you'd be interested in seeing in the future. And we hope to see you back next month for another session. So thank you very much.